There's so much confusing and conflicting information out there around pregnancy and birth, and none of it comes from the people that are actually in the room. We are Sarah and Catherine, two Canadian labor and delivery nurses with over 4,500 births under our belts.
What if the nurse holding your hand during labor could also answer every question you were too nervous to ask your doctor?
4,500 births later, we have Dr. COVID Lee, COVID with K, Lee, in the house tonight. And he's going to talk about the ARRIVE trial and inductions of labor. So Dr. COVID with a K, Lee, can you tell us a little bit about yourself?
Yeah. Thanks for the intro. My name is COVID, with a K, not with a C. My mom liked the name David and like the letter K, and that's where my name came from. So it's a completely made up name. My brother's name is Kogan because she likes the name Logan and likes the letter K as well. So they're completely made up names. Anyways, that's a little bit about me already. So I was born and raised in Calgary. I've actually lived here all my life. Schooling wise, I actually grew up in a family of engineers. So my dad and my brother were both engineers. I thought I wanted to be an engineer. So I went to engineering. And after 4 years of engineering and a couple years in industry, I realized that it wasn't for me. So I shifted gears, and I've always wanted to do medicine, but never found myself as a competitive kind of guy, and didn't really strive for those grades when I was earlier in engineering. So I actually went back to school while I was an engineer. I had a lot of support from some engineering professors as well as my engineering boss at the time as well. So he supported my dream of going into medicine. And after a couple applications, I got into University of Calgary, where then I did my residency and fell in love with obstetrics and gynecology, and where I also did my training here in obstetrics and gynecology for 5 years. And now I've been in independent practice at the Rocky View for now 7 years. So
that's awesome.
Yeah.
And I understand you're also a father?
Yes, father of two. I've got a 3-year-old and a 1-year-old. Yeah, 3-year-old turning 3 actually this weekend, and our 1-year-old just turned 1 like a month ago. So yeah.
Sweet.
Busy guy.
Yes. Yeah. Especially at home, but it's easier at work.
Oh, yes. We know that. You want to tell us what your passion is and what you're going to be talking to us about today?
Yeah. Well, I mean, obviously I love obstetrics and gynecology for a lot of different reasons. Specifically, I love the mix of medicine and surgery. The one thing that I really love about the specialty itself is the fact that you have that continuity care, but in a surgical setting. So I love looking after patients long-term. So developing a rapport and a relationship with them, whether it's multiple pregnancies or after being pregnant, maybe potentially looking after some gynecological issues. So I find that continuity of care in that surgical setting is very unique to obstetrics and gynecology, and it kind of carries over amongst both the subspecialties of obstetrics and gynecology, and specifically, which is why I'm here. So thank you guys for having me. But one thing that I am very passionate about, which I talk to all my patients about that are pregnant, is induction at 39 weeks, or as you mentioned already, the ARRIVE trial. It's something that I just almost broach the subject with every patient, even with our first meeting. Now, sometimes it doesn't always work out that way where they make it to 39 weeks. So there's other medical indications as to why we have to deliver them earlier. But I always kind of plant the seed and almost kind of let them do a little bit of research on their own as well. And as we develop that rapport and relationship, we take it week by week, especially at the very end there. And then we see how they're feeling at that time.
Very good.
So tell us a bit more about what you tell your patients. Like, let's pretend that we're patients of yours.
Yeah. Okay, perfect. So I'd say, hey, sir, how are you?
Great.
My name's COVID with a K, not with a C. It's nice to meet you. My mom says I'm just as infectious. So first of all, I explain my role, what I'll be doing, how I'll be looking after your pregnancy, how often we'll be seeing each other. I always talk about where to present if there's ever an emergency, when to talk to me if they think it's not an emergency, but they want to be seen a little bit sooner.
Go ahead and tell us like the whole spiel.
The whole spiel.
Yeah, when you're saying if it's an emergency, where to present and what would be an emergency, because we're thinking of our listeners out there, right?
Well, I don't want other obstetricians to steal my lines. I feel like I'm popular for it. No, I'm just kidding. So I can actually give you the whole spiel then. It does sound, even though it's not rehearsed, it sounds rehearsed. So I always mention that after 12 weeks, I would like you to go to the Rocky View Hospital on the 6th floor unit 62. So we have a dedicated emergency just for pregnancy. So even if you don't think it's an obstetrical emergency, still go to the 6th floor unit 62, just because we obviously have to clear you obstetrically, even in the case that if it's, let's just say, a medical emergency that's not pregnancy related, we still need to make sure that you and your baby is okay. So always present there first if it's an emergency. I always mention, depending on when we see the referrals too. So oftentimes I don't see patients until either late second trimester or even very, very early third trimester. So we see them quite late. Obviously, we triage our referrals appropriately as well. So patients that might need to be seen a little bit earlier in the first trimester, or even potentially right at the dating ultrasound, we'll obviously see earlier. But in general, what I say is after I see them, I say I'll see you guys every maybe 4 to 6 weeks until you're about 28 weeks. And then every couple weeks until you're about 35 weeks. And then every week after that, till you deliver. So we'll be best friends by the end of this.
And that really does happen for you.
Yeah,
we see it all the
you are
time.
quite popular.
I do mention that on the day of their delivery, it might not be me that'll be working that day, it might be one of my colleagues, but we do work in a call group and we trust each other with our patients. So, but one thing I do mention at that time too is that I'll definitely see them postpartum and I'll visit them in the hospital as well. And that's when I broach the subject already about the 39-week induction. I don't mention that specifically, but I say, but if for whatever reason we have to induce you, or we have to plan a delivery date for you, or if we want to plan a delivery date for you, we could try to plan a day that I'm working so I can be there for you. Now, obviously, what matters most is the baby, the mom, the family, the health of obviously all those people more than my schedule, but sometimes it's an added benefit. And I love being there for my patients. For that continuity of care as well. So, and then I always kind of say that if it's not an emergency, but you want to come see me sooner, I usually work in clinic at least once a week. So they can always call the clinic at any time, and I'm happy to see them on a weekly basis if need be. And I check my messages almost. I'm pretty OCD about my messages, but I almost check them every 24 hours. So if patients do have kind of concerns that feel like are not an emergency and they just call the clinic, I'll usually get back to them within 24 hours.
Very nice.
Yeah.
Wow, impressive. Can we talk a little bit more in depth about the induction process, your risk benefits, alternatives, that sort of thing?
Well, that's actually a good point too, because you bring up the whole informed consent about everything. So I love the acronym PRAX. I'm not sure if you've ever heard of that acronym. So it stands for procedure, rationale, alternatives, complications, and sequelae. So I find that if you prac somebody, you get an informed consent because you've really reviewed everything that they need to know about what they're getting themselves into or what they're signing themselves up for. So induction can be a little bit complex because obviously we induce for many, many different reasons, whether it's, ruptured membranes at term versus maternal choice versus if they go post-term. So there's a lot of different kind of reasons as to why. And the risks do change based on also the reasons why. So let's just say risk for cesarean section. If you're inducing maybe a patient because you're worried about the placenta starting to expire or the baby's maybe compromised in what way. So we sometimes talk about, well, the induction process, your baby might not tolerate that. We might be at a higher risk of cesarean section, but obviously talking about the risks of carrying on the pregnancy instead and what the risks not only to mom, but baby can be as well. So when it comes to induction, I feel like, and when it comes to pregnancies in general, I feel like everyone's care is very individualized. And what I mean by that is that there's no blanket statement to say, okay, if we're going to induce you, it's going to sound the exact same as every other patient out there. Everyone's induction experience is going to be very, very different depending on the reason why, and also depending on how the pregnancy has been up to date until then as well.
Right. Do inductions increase your risk of having a cesarean section?
And so the ARRIVE trial actually says no, and that's actually pretty black and white as well. So there's actually some pretty good studies, but specifically the ARRIVE trial that mentions that if we induce at 39 weeks, obviously if it's done properly, we actually reduce the risk of cesarean section. And how I talk to my patients about that and how I rationalize that as well, because a lot of people, I find that it's not necessarily that they, or maybe induction gets a bit of a bad rap as well. But I think that when you kind of look at all the stuff out there, a lot of people find that when they're being induced, either they don't want to be induced or they feel like carrying the pregnancy on further is just how it's supposed to be because their body will kick in when they're ready. And we don't really know much about labor, to be quite honest, which is why, I mean, if we really understood labor at the end of the day, we would be able to stop it, but we can't. So we don't understand labor fully.
And sometimes we can't start it.
Exactly. You're absolutely right. Right. And sometimes we do have those either, arrested progresses in the first stage and sometimes things don't progress the way that we like. But when I talk about induction, and this is more specifically at a 39-week induction, so some assumptions that we do have to make, which also apply to the ARRIVE trial, is that mom is healthy and baby's healthy. So there's really any other type of kind of medical indication to induce. But when we induce at that stage, this is what I tell my patients, is that we're starting a marathon with a gas tank full. So the assumption is that at this time, the placenta hasn't expired yet. Also, we know that baby isn't going to be too chubby. So even though a big baby, I mean, I love
They're
big
cute
babies.
though.
Yeah,
But I know
they're
it's more
yeah,
difficult.
I love chubby cheeks too. But sometimes a big baby doesn't always mean a good baby. And I think that also is sometimes maybe misrepresented when people are just like, oh, my baby is small or small for gestational age. Shouldn't I keep this baby in longer to allow baby to grow and get bigger? But in fact, that's really a sign that the placenta is no longer functioning and that baby would actually do better out than in. So I find that our jobs as obstetricians is really to determine when's the best time to deliver a patient. And the best time is probably the day before the placenta expires. But it's a bit of an art. There's no real way to tell 100% for sure, okay, your placenta is expiring today, therefore we should induce you yesterday. So obviously we have a lot of different metrics like blood pressure, weight gain, symphysis fundal height, ultrasounds, but nothing is really perfect. But that's what the ARRIVE trial also challenged in a way where they said, well, at 39 weeks, maybe your placenta actually, or maybe all placentas tend to expire around that time, even in healthy pregnancies. And some of the evidence and some of the outcomes actually does support that, because typically deliveries at 39 weeks result in better neonatal outcomes. And we also reduce the risk of cesarean section for moms, which again, anyone who wants to have a vaginal or attempts for a trial labor anyways, wants typically a vaginal delivery. So for that reason, it is something that I broach with all my patients and give it as an option if they choose to elect to do so. Like speaking to your first point where it's like, how do I introduce myself and what's my spiel in the very beginning? But I do broach the subject, but then I drop it for a little bit and just see how the pregnancy proceeds. And then once we start seeing each other weekly, we develop that strong rapport. We talk about it a little bit more. And I mean, every pregnancy is different too, right? Some patients, especially at the very end of the pregnancy, sometimes they're just done being pregnant. Sometimes they just have a tough week. And then the week after, they actually feel great. So we do take it kind of day by day, week by week. And I don't hold any patients to anything either. So a lot of times when it comes to the 39-week induction, even though it's something that I do advocate for and I do like, it's not something that I ever force my patients on, especially if I don't feel it's medically indicated. So a lot of patients who maybe value and want to experience maybe the going into labor naturally, that's something that I am totally in also support for, as long as obviously it's medically safe to do so.
Right.
So sorry, Catherine, it's been quite a shift. Like both Catherine and I have worked in obstetrics for a long time.
Yeah. You guys are very good at it too.
Thank you. And when I first started in obstetrics, inductions were done routinely at 41 weeks plus 3 days.
Yeah.
Unless there was a medical reason to induce before then.
Of course, yeah.
And so this big shift the other direction. And is that all based on the ARRIVE trial or other things?
I think it's other things too, because it's no secret that the placenta definitely has expired at 41 weeks. So I'm sure that you guys have seen it because you're obviously working on labor delivery all the time too. But how often do we see maybe 41-week inductions where the baby is all of a sudden maybe small? Or how often do we see a post-8 induction where now there's low fluid, or they don't have an 8 out of 8 biophysical profile? And these are kind of all signs that the placenta has started to expire. And for that reason, these patients are also now at higher risk of cesarean section, because not only is baby chubbier, but not necessarily a good chubby, but now because the placenta is starting to expire, they're starting this marathon. Labor is really a marathon, but they're starting it with not necessarily a full gas tank anymore. That placenta is already kind of running maybe at 39 weeks, or maybe even earlier than that, or maybe even later than that, truth be told. But we know that a 39-week placenta is a perfect placenta. But at 41 weeks, we definitely know at that point in time the placenta is starting to expire. And that's also why we see from and I know that we kind of use these terms a little bit loosely, but when we talk about term, late term, and then post term, but the risk of stillbirth does go up. And obviously that's also a reflection on the placenta starting to expire. But one thing that we do commonly see with, I would say, post term or late term pregnancies is oligohydramnios, which is low fluid. And this is what I try to talk to a lot of my patients about, is that babies are really smart. So when the placenta is starting to expire, or when they're really struggling to maybe potentially survive in the belly, what they do is they shunt blood away from the less important organs and to the more important organs. And we kind of deem the more important organs to be the brain, the heart, and the adrenals. And for whatever reason, we deem the less important organs to be the kidneys. So a lot of times when we see a post-term pregnancy or a late-term pregnancy, we see oligohydramnios because the kidneys are no longer getting as much blood flow. So the babies are producing less urine, hence the lower fluid. And as a result, in labor, sometimes we see heart rate abnormalities secondary to maybe cord compression, or again, the baby starting a marathon with not necessarily a full gas tank. So a lot of times when we see these post-term or late-term inductions, not to say that they all result in cesarean sections, but I would argue that they are, and actually the ARRIVE trial would agree that they're higher risk of cesarean section for exactly those reasons.
Mm-hmm. When you're booking these inductions, do you consider the strained healthcare system in Canada?
Absolutely. And I think that's also the beauty of actually booking these inductions. And I mean, like, obviously at the forefront, and what we should really prioritize is just patient care and patient satisfaction. Now, with public health care and obviously with, staffing issues and capacity issues and resource allocation, we know that, every patient that would want a 39-week induction won't be able to come in at 39 weeks. And they also understand too that there are potentially other babies or moms that are very, very sick that might take priority over things. And it's not to sound like we're managing patients based on also managing a ward, but we kind of are. That's part of our job, is to manage and juggle a lot of these things all at the same time. And obviously, in an ideal world, I would love to deliver all my patients at 39 weeks. And some of my patients would like that too. But a lot of times, and as you guys have probably seen too, that there are a lot of maternal choice or inductions at 39 weeks that get delayed, 5-6 days. I do, though, think that there is benefit from almost like a managerial and flow from a unit point of view to also book these inductions, because we know that if mom and baby are both doing well and it's around 39 weeks, we do have a little bit of room to play. And what I mean by that is that a baby doesn't have to come out exactly right at 39 weeks. 39 and 1 is totally fine. 38 and 6 is okay as well. Even though a 38-week baby arguably does not do as well as a 39-week baby, even though they both do fantastic. But 39 weeks is a sweet spot, and that's what we would aim for. But I think that if we have that little bit of flexibility, knowing, hey, mom is healthy and baby's healthy, so there's no real absolute urgency to get these inductions done, we can maybe call them in when the unit's not so busy or when it's not so hectic. And in that way too, I think it helps not only with unit flow, but again, sometimes we get bottlenecked. And I know that it's also difficult to say, because a lot of these, post-term or late-term inductions, these are the ones that we can't really wait on, right? Like when someone's 41 and 3, like what you said, the risk of stillbirth goes up significantly after 42 weeks. It's almost exponential. So we don't really have that time to kind of play with these inductions. Whereas at 39 weeks, when they're booked and ready to go, and as long as there's expectations to know that, you might not get called the first day or the second day, but knowing that you're on the list, I think it also helps with unit flow as well. And I think it makes for a safer unit as well, especially when it can be very busy, which I know it has been as of late for everywhere as well. Yeah. So, yeah.
Yes. Just another question with the ARRIVE study. The study was tested with, is it true, 20 to 30-year-old women? It didn't test
healthy first-time moms. Yeah. So primes.
From my experience at our hospital, our average age, I would guess it to be greater than 30. So can you see?
Yeah, and you're absolutely right. And I mean, I think a lot of the data from the ARRIVE trial has been extrapolated a little bit. And so, I mean, you're not wrong. First-time moms, young, healthy. So we're not talking other potentially medical conditions like advanced maternal age, which we would also recommend induction at 39 weeks. So usually what we do and what I would do with a lot of my patients is I mention that, hey, the study might not necessarily apply to you, but the concepts of maybe the physiology behind why, or the reasoning as to kind of why, would maybe still apply. So you're not wrong in the way that the study does have a specific subset, and how there is an element of extrapolation with a lot of that stuff as well. But I do think that the theory behind it and the medicine behind it is sound. So I do think that it can be applied to other patients, even though technically that study does not actually apply to those patients per se. Right. Yeah.
Okay.
Yeah.
Okay.
You don't have to go to the hospital, do you?
No, I'm actually not on call.
Oh, you're not?
We picked a good day.
Okay.
Yeah,
I
okay.
just,
saw
I
a
honestly
call
just had to help I just had to help my kids go to bed. So that was it.
You're a good man.
Yeah.
Do you want to talk about anything else with the ARRIVE trial, or do you want me to move on?
Is there anything else you want me to say about it?
When you are with your patients and you tell them about the induction process,
Yeah,
what do you tell them? Like the modes of induction and
exactly. Yeah. So that's a really good question because induction, obviously, and kind of what I talked about before is very individualized with every patient and every pregnancy as well. So depending if their cervix is closed or whether it's favorable, which means that their cervix is open enough where we can break their water, whether they're a first time mom versus they've had multiple pregnancies in the past versus if they've had a previous C-section or even two C-sections. So usually what we do is at around 38-ish weeks. So about a week before we decide that we want to induce, we'll talk about it again. We'll check their cervix. And if their cervix is favorable, then we talk about the process where they'll get a call from the hospital once there's a labor and delivery room available. And then at that point in time, we'll break their water and have a beautiful baby. Whereas, let's just say if their cervix is closed, we talk about, first of all, cervical ripening. So we do have to get that cervix to the point where we can break your water. That does reduce your risk of a cesarean section. So it should be done properly. So we always talk about Bishop's score, favorable cervix. So there's different modalities. We can use prostans, prostaglandins, or mechanical methods like the catheter. Mechanical methods obviously would be the only option if you've had a previous cesarean section, as prostaglandins aren't safe when you've had a previous cesarean section. Did I say that right?
Mm-hmm. Yeah, you did.
Yeah.
But you also earlier said 2 C-sections.
Yeah.
So are those pretty case by case or?
Again, case by case. There is medical literature that says that it's technically still safe. Now, again, and this would have to be more extrapolated as well, and we can go down a whole nother, if you want to invite me again on another podcast.
Okay.
But having a trial labor after 2 cesarean sections, so that's not necessarily a hard contraindication. So we do have hard contraindications to having a vaginal delivery, but having 2 cesarean sections is not. Now, is it recommended? I mean, there's a lot of people that feel more comfortable for people to have another repeat cesarean section if they've had 2 cesarean sections, but you can still try. But it's hard to quote risk of rupture and potentially the risk of obviously failure of the induction as well. And there might be some people that might not even be able and willing to offer an induction because it's hard to counsel. And obviously a lot of people, if they can't prax a patient properly, then they might not feel comfortable in offering that as well. And sometimes that risk of rupture is a bit of a question mark, although knowing that it can be safe still.
So when you say risk of rupture, I'm just thinking about people that'll be listening to this and not our colleagues, but the general public.
Yeah. So risk of uterine rupture. So that previous scar opening up. So obviously when you've had a previous cesarean section, there's a scar on the uterus and that could be a point of weakness. So anyone that's a trial of labor, I mean, we call anyone that's trying for vaginal delivery a trial labor, but a trial labor after cesarean section, we have specific criteria for them. One of them with the induction process is they can only have a catheter or a Foley. So the only way that we can ripen the cervix if they need ripening would be mechanical because the risk of uterine rupture, so that previous scar opening up, if you're given a prostaglandin is extremely high. In addition to that, there are certain protocols with oxytocin that we do kind of follow with trial labors as well. A lot of people like to go low and slow. There is different oxytocin protocols in general. So there's the low dose and high dose protocol. Alberta uses a low dose protocol. So we go up by 2 every 30 minutes, up to 20, and then we can reassess. But there's some places that actually go up by 4 and they go all the way up to 40. Now that is not recommended in a trial labor. Usually you would go up by only 1 or 2 and then you would reassess it. You could go up to 20 studies show that are safe, but some providers might only be comfortable going up to maybe 8 or 10. So for those reasons, that's also why when we talk about induction and inductions in specific cases like 2 previous cesarean sections, we have to make sure as well that all the providers are comfortable in looking after those patients because obviously we all want to provide the best care possible, but also informing our patients of the risks that they potentially could be undergoing. So yeah.
How long do inductions take?
That's also individualized. So I don't commit to anything. So I could tell you another line that I use with a lot of my patients is that if I could tell how long it would take, I wouldn't be working. I'd be in Hawaii sipping a pina colada. So again, every labor is truly different. Every induction process is different. So whether you're being induced with or cervical ripening with a prostaglandin or a catheter, I mean, typically catheters should come out within 12 hours, but sometimes we've seen them in for longer. And sometimes we've seen catheters fail. Sometimes we've seen patients with multiple prostaglandins and multiple different types of prostaglandins, so PGE 1s and 2s. So misoprostyls, Cervidils. At the Rocky V, we don't use Prostin, but we've had patients with multiple doses and their cervix just does not open. In addition to that, we've seen oxytocin. So we've seen patients being on high doses of oxytocin for a long period of time. And sometimes we just get an arrest of progress. And it really lends itself into us and our lack of real just fundamental knowledge on really how labor works at the end of the day. We obviously know a little bit of it, but we don't know all of it.
So are your patients aware that if they have an unfavorable cervix, that they could potentially be spending days?
Yeah. And I do let them know that too, that obviously depending on their cervix, that the process, so the day that we book their induction will likely be not the day that they meet their baby. It'll probably be days after. I usually am more confident in quoting that once we break your water, we do anticipate a delivery, and this is for first-time moms, 18 to 24 hours after breaking your water. But to get your cervix from unfavorable to favorable, that can be very variable. Yeah.
Yeah.
Now, a lot of people are kind of reluctant to get inductions, kind of a negative word around obstetrics. Tell me when it is routine and when it's necessary to get an induction.
Yeah, that's a good question. So obviously we induce because we feel like, and the only reason why we induce is because we think baby is going to do better out than in. Or in addition to that, we feel like whether it's maybe a risk to mom's health to keep the pregnancy in for longer. So obviously I focused on maternal choice for being induced, but there are multiple medical reasons as to why we would also want to induce. But going back to,
if you could list your top 3 baby needs to come.
Well, the most common reason why we induce is ruptured membranes at term, but sometimes just patients don't go into labor. And again, that lends itself into, we don't really understand a lot of it. Now, obviously water is rich in prostaglandins and it helps put more pressure on the cervix and helps maybe engage more into the pelvis. But sometimes when patients break their water, they don't always spontaneously go into labor. So that's one of the most common.
What's the risk there if I don't want an induction after my water's broken for 48 hours?
Great questions. So obviously, the longer that we wait, the risk of infection goes up, risk of postpartum hemorrhage goes up, risk of cesarean section also does go up as well. So it used to be that they only recommended induction right away if you were group B strep positive. But now the recommendation is just to get the induction process started right away. Now, obviously, I know that in reality, it doesn't always work out that way when, let's just say labor delivery is very busy. We know that we can still afford a little bit of time and potentially the body might kick in on its own. But typically, usually anywhere in the round of 12 to 18 hours after, we do run the risk of potentially infection and bleeding in mom after delivery as well. And again, the risk of an increased risk of cesarean section. So fetal intolerance to labor is something that we do often see. But that would be the most common reason why we induce patients. But one thing that I tell patients also late in the 3rd trimester, which is why we see them weekly, is because even though it's awesome to listen to the heart rate, and I know that that's really special and important, really the most important reason why is because we're monitoring blood pressures and gestational hypertension and preeclampsia, which really lends itself to the first sign that we think the placenta is starting to expire, is the reason also why we induce a lot of patients.
If you have any questions about what you heard today, please reach out. Sarah and I would love to hear from you. Email us at birthslater@yahoo.com. That's birthslater@yahoo.com. We are here to support you every step of the way. And now for the legal language. This podcast is solely for educational and entertainment purposes. This podcast is not intended as a substitute for professional advice from qualified individuals involved in your prenatal, labor, and postnatal care. Every pregnancy and birth is different, so always talk to your healthcare provider about what's right for you.